to talk through this and take you through the journey that Police Scotland has gone through in respect to naloxone and getting to this point, and also a wee bit in my personal journey, actually, which will be roped up into this, where I've moved from I suppose initial hesitancy to I suppose you could call it zealotry in respect to this. But being a zealot in this doesn't come from just the fact that I happen to be in charge of the project. I think it's from the point of view that this is not only the correct thing to do for policing, but the necessary thing to do for policing. It comes from the fact that there is no evidence to the contrary on that point. It's not an argument, therefore, because there's no valid position against it. And I really am done being nice and diplomatic on this, and so I'll be fairly forthright through the course of this presentation on what are presented as the arguments against this, because there's a real fear for me here that there's a reputational risk in the arguments that are presented by so-called representatives of the service, because none of these arguments, in fact, all of these arguments are at odds with the broader policy and mission and ethical duty of policing, in my view. They're at odds with our moral duty as fellow human beings and citizens. They're at odds with all evidence that exists there. And quite frankly, I think they're an affront to policing values. So these are not arguments at all that are to be respected, but in fact, I think they should be suspected as to where they come from. So it does sound a bit controversial, that, and I want to focus on the positives of what we've done so far. But I think it's really important now to actually start speaking frankly about this as a service, and start changing that narrative of something that this is something that divides opinion and is worthy of discussion and conversation, because it's not. It's absolutely quite clear to me, and it should be clear to anybody who's taken the time to look at the evidence, that this is something that policing should and indeed has to do. So that's it by way of opening. I'm just going to take you right to the Scottish context, and that's probably something that you've seen before. That's the drugs deaths per million, and these are 2018 figures. 2019 figures are the same. 2020 figures have not been published yet. They're not going to be much better, and that just shows you the difference. I find that a horrifying chart to look at. Scotland is 4 times worse than the next worst country, which is Sweden. If you took Scotland out of the UK, the United Kingdom would come far further down that list there. The reasons for this are complex, we know, but one thing I think we can say is that they're cultural, and therefore they deserve a cultural response, and that needs every cultural institution to do. If not its best, then at least its least, to try and address this. There you see the record numbers of drugs deaths in Scotland. This is actually 2019 figures, and you'll see about 80% of them involve heroin or other opiates. Benzodiazepines, street Valium, etc. are beginning to show up as well, but still a huge number of drugs deaths in Scotland are opioid related, and that's the context in which we're operating from. As a result of that, the Scottish Government introduced the Scottish Drugs Deaths Task Force in 2019, I think it was, around about summer 2019. So that's a large group of representatives from health and justice and the third sector and support groups and academia coming together to try and find a way through the crisis and try and find some answers and some solutions that are going to be long-term and sustainable. So I'm the representative for Police Scotland on that. I represent the Chief Constable on that group. At the very first meeting, I met Kirsten Hospera, who if you haven't already met in this group, you'll meet later today. And one of the first things that Kirsten said to me was that police officers should be carrying naloxone. Now, I was hesitant at that point because the Scottish Police Federation, we were still in speaking terms at that point, had spoken to me in quite strong terms about how this is something that we shouldn't do. And unfortunately, I hadn't bothered at that point to really read into it. I knew what naloxone was, but I kind of took their word for some of the positions that they were saying in terms of things that we'll come on to, like taking on demand, potential side effects, etc. After Kirsten had a conversation with me, I decided to do my own research. And of course, it took me about 10 minutes to first of all realise that this is something absolutely that Police Scotland, particularly Police Scotland, should do. And secondly, if I'm being quite honest, to feel a bit ashamed about my initial hesitancy. And so that led me to be quite committed and to be completely committed in making sure that we could do something in Scotland, because policing required to make a response. Now, the Scottish Drugs Test Task Force have a lot of work streams, and I don't have time to go through all of that today. Some of it's about legislative change, some of it is about better outreach, etc., better health programmes. But we're looking at naloxone. One of the things that we are doing in Scotland is a take-home naloxone programme, trying to get far more naloxone circulating in society. And that's been successful. You see the banner there from NHS Lothian. And of course, these are syringes, which was one of the big problems, the big reasons for opposing this from the staff associations, the Federation in particular. But of course, that's not what was proposed for policing. It was the nasal spray, and that's exactly the spray that we are using in the test of change in Scotland there that you see. Proposals for police carrying naloxone had been discussed for a couple of years, didn't really get very far. There was a working group under our People and Development function, and our Deputy Chief Constable Fiona Taylor chaired that group, and really got into the detail and the evidence and I suppose the research behind using naloxone. But there was really strong staff association opposition on that group, so it didn't really get very far. It never garnered much traction. However, it was presented the position of that group in respect of proposing that Police Scotland should look at carrying naloxone was presented to the Senior Leadership Board actually in January 2020. And at that time, the Senior Leadership Board is all executive members, Assistant Chief Constables, Directors, Deputy Chief Constables, and chaired by the Chief Constable. At that time, support for it was about just over half the executive at that point were supportive. The Chief decided to take it off table and think about it for a little while. He spoke to me about it for a little while. And then in the Senior Leadership Board in February 2020, he decided that we would do a test of change and that I was to lead that. So it's worth just bearing in mind that at that point, almost half our executive were, for one reason or another, unsupportive of that. As I said, the proposals to be developed for a test of change as a result of that. Now, you'll see the date here, the 17th of February. This was the Scottish Police Federation's first circular, laying out its argument against the police carriage of naloxone. Now, this is in actual fact really helpful to me, because what it did was it laid out very starkly the Federation's position and the points that I had to address in order to run a successful test of change. So, in setting up the test of change, I established a delivery steering group, which involved partners, including Kirsten for the Scottish Drugs Forum, including Health, and academia and internal representatives as well as of the organisation, and Scottish Police Federation and Staff Association representation on that steering group. The first meeting was on the 12th of March 2020. Let's say there I just told you that. One of the things that we had to do was identify test bed areas. We weren't going to do this across the whole force. We decided that we wanted areas that we thought best benefit from the police carrying naloxone and give us that evidence base that was perhaps missing in respect of persuading the executive to make this a broader policy. Wanted to establish an evaluative framework as well, which would go beyond just the interventions that we actually make in trying to save someone's life and actually look at attitudes. We consider one of the big problems that leads to such a high rate of drugs deaths in Scotland is stigma. People feel marginalised, they don't feel part of society, they don't feel as if anybody particularly cares. So one of the things I wanted to do was look at how those attitudes might change if people who are living with addiction, people who may have had overdoses in the past, if they see a service who, and let's be honest, generally their contact is in a negative sense. Generally it's because we're taking criminal justice interventions against the crimes that are just one of the outcomes of their addiction. How would their attitudes change if they actually saw and knew that police officers were carrying naloxone in order to save them at their worst point, actually, or save them if they were dying? And as I said, address the issues that were raised by the Federation in their initial circular. Then, unfortunately, this chap came along and that kind of derailed things for a little while. So we didn't have the second meeting of the test to change until July 2020. And at that point, I was able to set up a monthly battle rhythm for the meeting. And by that point, we'd still continued to do work in the background, and we had identified the 3 test bed areas. The east end of Glasgow, Dundee and Falkirk and Clackmannanshire. So the first 2 are obviously very urban, heavily populated areas, and 2 of the worst areas in respect of drugs deaths in Scotland. However, they are also 2 of the most forward-thinking areas in respect of addressing that. And in Glasgow East, we have a positive outcomes project, strong partnership links, a very strong alcohol and drugs partnership there. And so the partnership framework was fairly well set up. Dundee is the same, and I'll come on to that a bit later. And Falkirk and Clackmannanshire are more kind of semi-urban rural areas, perhaps with not the same type of partnership frameworks in place. But yes, again, one of the highest rates of drugs deaths in the country. So that would include about 700 police officers in total working in these 3 areas. Population 600,000. As I say, high rate of drugs deaths, also strong partnerships. My plan was from the last day of training to run the test to change for a full 6 months before we do the evaluation. At the end of that 6 months, we wouldn't take the naloxone that we've rolled out back. We would continue to let officers use it and carry it. It just wouldn't be part of the evaluation. We'd draw the line for the evaluation after 6 months and use the evidence that was provided in that period. Very strong communications plan, both internally and externally. Internally, to try and counter some of the issues and in inverted commas arguments that had been raised by the Federation, and externally, of course, to highlight the fact that that police officers were now doing this. Again, to give us that evidence about how that affected public attitudes. Evaluation, as I say, covers all these different dimensions, and it's done independently by academic researchers. One of the keys for me, and again this was addressing something that the Police Federation had raised, was to train every officer, to create a training package, deliver it to every officer in person, but at the end of that, give the officers the choice themselves whether or not they wanted to take part in the test of change or not. I think it was important to gauge police officer attitudes in this also, and that would give us the opportunity to do that. So just touching for a moment on the Federation issues that they raised. First of all, safety. So they questioned the fact that naloxone was safe, and one of the many questionable quotes that we heard was, "No one's ever died from the police not having naloxone," was exactly the quote. However, people have died after having been given naloxone. So, you know, not factually inaccurate, but casuistry is at its very best, I think you would agree. So the safety element was played really highly in that to make people, and it's pure scaremongering as far as I was concerned, but to cast doubt in the minds of our officers that they could somehow cause harm if they gave somebody who was dying at their feet naloxone, and that they could be held to account for that afterwards. Broader safety aspects also were the fact that if you give someone naloxone, you've seen what happens in the movies. They spring up, they're agitated, they're aggressive, and you could be in a tricky situation there because you're faced with an aggressive person. Again, for me though, and I think for most police officers, as you'll see, the choice is, you know, we deal with aggressive people all the time. It's never acceptable. It's always stressful. However, is it better then just to let a person die at your feet rather than face that very small risk that would happen? And of course, it's very unlikely for that to happen. The person's going to go into overdose symptoms at that point and probably remain drowsy or drift in and out of overdose. The small rescue amounts of this first aid naloxone that you're given. So that was a safety issue first of all. The second issue, which was maybe a bit more valid at the time, we as a service, and I'm sure it's the same everywhere, catch a lot of failure demand from the ambulance service at the moment. The Federation said that if we took this on, then the ambulance service are just going to stop attending overdoses. So that was something that we had to address in a bit of detail. Now, in actual fact, as soon as I spoke to the ambulance service on that, they said, well, no, we wouldn't. That's somebody dying. That's a priority for us. And as long as we get the right information at the time from the location, that's always going to be a priority call for us, at which we will aim to get there within 10 minutes. I did get a written assurance from the ambulance service on that. But we also designed a process whereby, and this was new for us, and I don't know if other forces do this at the moment, where rather than going through our call centre to secure the attendance of the ambulance service, in the case of an overdose, we ask our officers to make that call to the ambulance service direct from their work mobile phones, their police issue mobile phones. And that allows them to have that exchange with the call handler at the ambulance service and give the correct information and confirm that an ambulance is attending as a priority prior to issuing naloxone. And that's a process that we've followed all along. So I've also given the assurance that should it look as if the ambulance service is for some reason downgrading their calls because police officers are in attendance, then I would stop the test of change. I would pause it and address that, and I wouldn't start it up again until that was addressed, because I couldn't then, with any hope of success, recommend that to the Chief Constable that we should take on the demand of an ambulance service for overdose people, for people in overdose situations who obviously need emergency medical assistance. Now, again, of course, the ambulance service are 100% behind that. This is not a situation that they cannot attend. The whole response framework is based around saving lives, and we've got somebody who we think is dying at our feet. Of course, they're going to attend that as a priority. And I think these concerns are completely unfounded, and we've got safeguards in place to address that. Now, the last thing, sorry, this isn't the last thing, but this is the last main issue that the Federation raised, and I think, and again, I would say I would be direct. I think a new low for the Scottish Police Federation in this respect, because this was just pure scaremongering. In their circular, their initial circular, they told police officers that for any issues that police officers may face in terms of legal challenge or criminal allegations resulting from their use of naloxone, then they would refuse to indemnify them. They would not give them the legal coverage that they would get in any other situation. So, as the police officers themselves have pointed out, you'll still cover me if I'm accused of murder or serious assault or domestic assault or sex offences, but you won't if I try and save somebody's life by giving them first aid in the shape of naloxone, which is exactly the position of the Scottish Police Federation. However, it's a complete and utter red herring, because of course officers are acting in the line of their duty, they're acting in good faith, therefore any legal issue that arises as a result of them giving naloxone would be covered by the force, would be covered by legal assist. But it's also a red herring as well, because I cannot imagine in any circumstance where anybody's going to question a police officer who's tried to save somebody's life by using an approved first aid method which they've been trained in and authorised to carry by the force. Now, the challenges that we face here in discussions with the officers is, yes, but what if that person then gets up, refuses medical attention, goes away, and thereafter dies? And again, what I say to the officers there is, well, if the person is well and you're happy that they're well and they're safe and well, then you've got no power to keep them there. If you're not happy, if you've got a concern for them, then you can keep them. If you are happy, then you can let them go, because you don't have the power, and you can never be criticised for not exercising a power you do not have. And as I'll come on to, we have had situations like that during the test of change. Not where someone's died, but where people have actually got up and left, either prior to an ambulance arriving or in attendance of the ambulance. But as I say, that for me, that was perhaps the most disappointing thing from the Scottish Police Federation. Broadly, the Federation say it's just philosophically wrong. You know, this is not something that policing should do. We should not be giving people medicine. So, but it's first aid to me, and that's the point I put across. It's a completely safe, regardless what they say, spray that's going to do nothing except reverse the effects of an opioid overdose. It has never done anything other than reducing the effects of an opioid overdose in all its life. We are quite happy to put somebody in the recovery position. Federation support that. They support us giving CPR and mouth to mouth. They actually support the rollout of defibs as well. The only difference with naloxone is that it's easier to use, safer for both the individual and the person receiving it, and in the case of an opioid overdose, far more likely to have a positive result than any of those things. So there is something philosophically wrong, but it's not in the police carriage of naloxone. So just moving on to the training. It was scheduled to start in January 2021, but as you remember, he came back, so we rescheduled it to start in March 2021. It was important that we did it in person. Now again, Kirsten will tell you herself, she said just do a 10-minute Moodle and give officers it at the end of it. But she quickly came to realise that the culture and the scaremongering and exaggeration and misinformation that had been put about there would really land with some officers and really make them initially reluctant to be involved in the test of change. Therefore, I thought it was imperative that the training was in person. I thought it imperative that I attend all training sessions. and provide that reassurance from the executive, and also be there to answer their concerns and their questions. I thought it imperative that Kirsten and her colleagues turn up and start speaking about the science of naloxone to ensure that safety issue was addressed. And we also had support from PERC, who are our IOPC. They attended to reassure officers that, of course, there wouldn't be an investigation if they tried to save someone's life, regardless of what happened to that person after that. There may well be looked at as a death following police contact, but their use of naloxone would be seen as nothing other than an attempt to save their life, and that's it. And bear in mind, officers are at the scene anyway. These are for situations where officers would have been there anyway. We are not attending things that we wouldn't have attended before. So they're either there at the scene as somebody having an overdose with naloxone or not. And if that person should subsequently die, there is still going to be potentially a referral for a death following police contact. So it was really important to have that dynamic and to allow officers to chat through, and I'll come on to that in a second. We arranged to do Glasgow and Falkirk in March. If I'm being honest, because we thought that would be the area where we would get the best response for different reasons that I'm not going to go into here, but we thought Dundee would be a pretty tough nut to crack, so we dedicated the whole of April to Dundee. But in Glasgow and Falkirk, we did side by side throughout March. In total, I think we did about 40 training sessions. We're not quite finished yet. We're still catching up with those that we missed. But because of coronavirus and the need to socially distance, we had to pick venues that were big enough to allow us to get a reasonable group of cops in. But that still took about 40 training sessions to get everybody done. 30 plus here, I think we're up to about 40. Federation, I'm not going to come off here. I would normally try and take you to this circular here, but I'm not going to come off because of problems before. This was the second circular that the Scottish Police Federation sent out as the training started. So this was about 8 months after their initial circular. So at that point, the Federation representatives had been at every delivery steering group. They saw that we'd addressed every point that they raised. However, they put out Circular 6 of 2021, which I think, if I'm being honest, the Scottish Police Federation will at some point in the near future regret. Because I've said before, their arguments amounted to nothing but casuistry. I think Circular 6 of 2021 is just pure old-fashioned chicanery. Still contains all of the issues that we had addressed, but again throwing in some exaggeration, conflation of issues that have got nothing to do with naloxone, further scaremongering, and at times falsehoods in an attempt to dissuade officers from carrying naloxone. Oops, don't know what happened there, folks. So our training consisted of inputs and videos. So that's our Chief Constable there. We started off by having the Chief giving a reassurance message to officers that the issues that had been raised with the Federation had all been addressed and that there was nothing to concern them. We felt that was important. Following that, I would go on and speak for five to 10 minutes, again, just reiterating that. We had a video there, I think you've seen this video during this, which Kirsten presented, just talking about naloxone. And then we had a few other videos from people who had lived experience. The lady in the bottom left, as you look at this, is the mother of an overdose victim who died, just talking about her experiences and thanking officers for volunteering. And we also had videos from our colleagues in North America. So this is Ottawa Police here, who've been using naloxone for a number of years with great success. So, and there was a few other videos there as well that we presented, along with, I say, a verbal input talking about the process, etc. And there's one of the training events in Glasgow. As you can see, we're all nicely socially distanced there, and that was a typical turnout for training. One of the things that we've also done was, because we were keen to ensure that the public knew we were doing this, and as I say, we're going to measure the attitudes of people who live with addiction as to whether this makes a difference or not. So we purchased a pouch with naloxone written in bold writing, as you can see, with some direction cards there as well, some advice cards for officers and to hand to someone who's been given naloxone, and it's carried on the police utility belts, highly visible. We also have a microsite. I'm going to try this to see if it works. Just to take you to our microsite. Might regret this. And as you can see here, that's our microsite there. We've got a document library there, which includes a policy, frequently asked questions, etc. And then a video library of all the videos that we've shown or planned to show, and others at the training, a few images and things like that. So that's actually a very well visited site, and it's been well worth our while, and we add to it all the time. That worked. So the response from officers. The first Glasgow session, we only had 8 attend, and only 2 volunteered out of that 8. And to be quite honest with you, given the I suppose the demeanour and the reluctance from the officers throughout the training programme, I was actually surprised that anybody took it. I thought we were going to leave that training session with nobody carrying it for our very first one. It was quite clear that the scaremongering from the Federation had landed, and the misinformation had landed, and we found it a real struggle to actually cut through that. Now, as I said at the start of the presentation, I'm done being nice and diplomatic about this, and that's probably because that's how we started the training programme, giving a bit of respect to the arguments that had been offered in opposition to this. Trying to constructively deal with them rather than face it head on. And we had some real soul searching after this to see whether or not that was the right way to go. And what we decided was, rather than trying just to shoehorn everything in, trying to shoehorn all the videos in, we would let the officers themselves direct the training programme from there on. So right at the very start, we ask our officers to ask questions, to raise the concerns that they have, and allow that to shape the training programme rather than trying to get through all the videos and all the presentations. And from the second session, things improved, although there was still some quite significant challenges. Then on the 9th of March, I had our first use. So 2 officers who had been at the training session that afternoon, literally 2 hours later, went to a call where it was a concern for person, and on entering the premises, they found that person in an apparent overdose. So they followed the procedure, used naloxone, brought the person round, who was still very ill, and ultimately he was taken away in the ambulance, which attended about 5 minutes after that. And that was a real turning point in attitudes for us, and we saw mass uptake from officers, generally mass uptake from officers in Glasgow at that point. At that point also, Federation officials started attending training. One of the things that they'd said in Circular 6 of 2020-21 was that they had been barred from training sessions, which was a complete lie, which is mandated in the Delivery Steering Group, where I personally, on 3 occasions, invited Federation representatives to come along. So I reiterated that in writing and publicly, so they couldn't deny that that was the case. And the officials started attending training. Unfortunately, though, initially, again, there's no other way to put it politely, there was attempts to hijack the training by speaking out, interrupting me when I was speaking, interrupting others when they were speaking, and it ended off with a bit of a standoff between ourselves and the Federation representatives. So what I then directed was I asked my Federation colleagues that if they're going to attend, please do, but we're not going to have standoffs. It doesn't help anybody. We're not going to have arguments in public about it, that they could attend, they could observe, and they could, after that, if there was any questions directed at them, they could answer those questions directly. But they were not to stand up and give an input and hijack the training, because we couldn't get through the training programme because of that. So they started attending the training. They didn't come to every session. They came to a few, but then they didn't come to many after that. With the second use 2 weeks later, again in Glasgow, and as I say, at that point there was widespread uptake. A different attitude altogether in Falkirk and Clackmannanshire. It started off very positive, but afterwards it really dropped away. And what we saw was, for some reason, real reluctance and real contention against it, particularly in Clackmannanshire, which was a bit more rural. Now that may well have been because of some particular cultural attitudes there, but we found that the Police Federation had gone really strongly into that area, and there was real strong Federation representatives on the shifts there. So I think that's had a real effect in Falkirk and Clackmannanshire. However, at the end of both sessions, and because of the catch-up sessions, this has changed a wee bit. We are now at 80% uptake in Glasgow and 60% still in Falkirk and Clackmannanshire. So in both areas, most officers, despite all the scaremongering and coercion from the Federation, are still involved in the test of change, which is great. Media response was very, very positive also. We went large in some places. This chap here, Stuart, was the second use. He's actually a special constable. He was happy to go public, and we get some really good features and articles in that, which I think is really positive for the service, and good to get the message out that that's what we want to do. And here's some of the news clippings that we have there. Now I'm doing Dundee here because I said to you, might remember that Dundee we thought might have been a hard nut to crack just because of some kind of historical issues in that particular area. But I'm giving Dundee a shout out. So there's the V&A there, there's Desredan and Minnie the Minx, the Discovery and the Caird Hall, because Dundee was fantastic, truly is the city of discovery. We were really warmly welcomed by the officers, who were universally positive about this. And again, to my shame, I feel bad about being prejudiced about the area. Great support from senior management there, and we ended up in our training in Dundee with over 90% of the officers volunteering, and we're not finishing yet. So where are we now? 672 officers have received training. We've got 527 volunteers, 78.4% overall. We're a bit more than that now. This is when I did this presentation last week. A couple of catch-up sessions takes us to over 79% uptake. We had one more use at the weekend in Dundee, so we've had 10 uses overall. On every single occasion, there is no doubt that the person involved was having an opioid overdose, and on every single occasion they recovered when administered naloxone to some extent. Also, on every single occasion, apart from one, the ambulance is attended within 5 minutes. The only one in Falkirk that was outside that was 15 minutes, and there was particular circumstances around that which led to that. But 15 minutes for an ambulance in Falkirk is apparently pretty good. We now have other areas asking us if they can get involved. They are volunteering, so we are now looking at extending the test of change to Stirling, where there's particular problems in one community, and believe it or not, to Caithness in the far north of Scotland, the far northeast, where there has been a large increase in the number of drugs deaths in the past year, and some very strong partnership working up there. So we're going to expand the test to change into these other areas. The Federation, however, remain implacably opposed to this, and really just to kind of call out their position, and these are positions that they've stated publicly. You know, that it's police officers' duty, or prime duty at the scene of an overdose is the crime aspect and the crime investigation, which it isn't, quite frankly. And also a line which again I think will come back to haunt the individual that said it was it's a police officer's duty to protect life, not to save life. So, but I don't really want to end on a negative. I think this has been already a fantastic test to change. One thing I forgot to mention was I took the proposals for the test to change back to the senior leadership board in November 2020. And if you remember, I said in February 2020, about half the board were opposed to this for one reason or another. In that time, I had kind of publicly canvassed everybody and tried to speak to everybody about it and encouraged them to do their own research into this. And the proposals for the test to change were completely supported by every single member of the executive by the time we took it back in November 2020. And that's because there is really no opposition to this. There is no reason not to have police officers carrying naloxone, no valid reason anyway. And I'm sure some people will try, perhaps even today, to raise arguments against, and they'll continue to do that. But these arguments only come from one of two places. They come from being ill-informed and not fully informed about the benefits of naloxone, particularly in Scotland, the need for it, and how it works and how it saves people. And I really don't like to think this, but it comes from traditional attitudes, which quite frankly, I think are at odds with a progressive policing service. So that's me. Thank you very much for listening, and I will stop presenting now. Thank you.
Thanks so much, Gary, for that really fascinating presentation. Really good to hear about the progress you've made and some of the challenges that you've experienced as well. And I think a few points we'll hopefully pick up again later on in the discussion. But for now, I wonder if I could hand over to you, Brad, to talk a little bit about the evidence on these programs from the United States.
Yeah, can you all see my screen?
Yes.
All right, cool. Let me just get this rolling here. All right, everybody. So I am a researcher and professor in the US in Detroit right now. I'll talk about some other cities that I've lived in and done research in, but that's where I am at right now. I like to start talks like this, just give everybody a sense of kind of my personal journey with naloxone, if you will. It was about 20 years ago. My brother came to visit us in Chicago, and I knew he was using some non-medical prescription drugs at the time. We went out to the bar, we had a good time, we partied. In the morning, he had it sounded like very labored breathing, very long hiccups. And that went on for almost over an hour, almost 2 hours. And in the process of that time, trying to move him, trying to wake him up, we found little baggies. Somebody said that they had heard that he had used heroin. Several of us didn't even know that. So, we kind of were faced with that situation that many people are in, which is like, what do you do? Do you call? What will happen if we call? Fortunately, we just went ahead and called. We called EMS and called 911. And the ambulance came, and after hours of trying to resuscitate my brother, they administered naloxone. He immediately came back to life. And so, as I'm sure many of you could imagine, like, that was just a miracle, game-changing moment in my life to just see somebody who, a loved one who I thought was going to die just come back to life. And it seemed very much like a miracle to me at the time. And so I got involved with research out of DePaul University. A professor there, Dr. Greg Scott, connected me with the syringe service program. So you can see some photos here of that. And my initial experience was, wanting to learn more about stigma, and then also wanting to sort of help inform these services, so where these harm reduction services could go. And so I did some mapping of where overdose deaths were occurring in Chicago, and learned a lot then about, ICD codes, overdose, toxicology results, things like that I'll touch on here in a second. So just to give a sense, I always like to kind of start with this so people know, so we're all on the same page. For about 40 years, the US has experienced exponential growth in overdose deaths. When we talk about these recent trends in overdose deaths, we talk about them usually across 3 or 4 waves over the past 20 years or so. You can see here that initial wave was brought on. So this is just the total number of deaths, and then these are the substances detected in those deaths. But that initial wave was brought on by prescription opioids, which eventually gave way to heroin, which eventually gave way to fentanyl, and now this sort of co-use combination of fentanyl with stimulants. This is from Marion County, Indiana, Indianapolis. So I was, and all the research that I'll be talking about here comes from there. I was a professor there for 7 years. And I started there in 2011, and the very first partnership I developed was with the deputy coroner, and we started to collect toxicology results in real time. And just really want to point this out to everybody here, some of these trends. Again, these bars are the total number of deaths. So in Indianapolis, they had about 500 deaths last year. It's a population of just under a million, about 900,000 individuals. And what you can see here, this here is heroin. And so this, and I'll talk about this in a second here, but when I first moved there, we were seeing this increase in heroin related deaths that was emerging, where we were already seeing a lot of increases in prescription deaths. But it was the summer of 2014 when fentanyl hit. And you can see fentanyl is in 80% of overdose deaths in this county now. And almost everything with the exception of meth is trending downward. So it started in late 2013, the conversation started as we saw heroin deaths increasing, but it wasn't until 2014 that we kind of got the approval to kick off training for law enforcement in naloxone. And I'll be very upfront with everybody that it was, for me and for many of the individuals involved, a necessary step in order to get naloxone to the community. So if you don't know this, EMS in the US has been carrying naloxone since the 1970s. We at the time in 2014 felt it was very important to get naloxone out to everybody in the state, but that there's no way that was going to happen. So what we wanted to do was kind of see getting naloxone to law enforcement as a first step. And I'll kind of go over some of that as we go. So the first thing we did these trainings. EMS led the trainings. We did them at all of the roll calls. They were primarily focused on how to detect an overdose, how to put the naloxone kit together, things like that. All of the officers were provided with a naloxone kit. They set up sort of a data collection form whenever they would administer one. We did a survey. We used the OOKS, it's referred to, the opioid overdose knowledge scale, which I'm not displaying that here, but that survey, overwhelmingly folks had positive feelings, officers had positive feelings about the training. And those individuals that had more personal experiences with addiction, with overdose, had better attitudes is another thing we found. But this is some of the stuff I wanted to show you all. When asked how difficult the training was, almost everybody, not difficult at all. How difficult would it be to use? Very many people, not difficult at all. How difficult would it be to train civilians? And as you can see here, 90% or more, not at all difficult, this is the exact evidence we were really looking for to be able to say, law enforcement, very simple, found it very simple to use, very simple to incorporate. So we should definitely move this out into lay populations. This and this kind of feedback was really what started to stimulate my further research into this. So how important is it for police to be at the scene of an overdose to keep medical personnel safe? And you can see 71% felt it was very important. And how frequently did they think it was important to be there to enforce the law? 36%. And about half didn't, or more even, did not think it was important that other officers be trained in naloxone. So while they thought the training was great, they really just didn't see that all officers needed to necessarily, there were some people that didn't think everybody needed to be trained in that. So we did this initial training. We collected the data from officers that were using it. And then what we did is a follow-up study. So after 18 months of use, we went back through all of the uses of naloxone by officers, and we read through the report, the EMS report. We looked at how frequently it was being used by quarter, and then we did some focus groups. So a couple of findings from that. One, to go back to something that was said earlier, the officers were very nervous about folks being combative. There was some discussion about setting up protocols to handcuff people before they administered the naloxone. Once they started doing it, once they saw the data, and I think some of this was the result of using the nasal naloxone, but as you can see, 1%, I think there was one individual actually who was combative, and that person still did voluntarily go to the hospital. Only 2% refused transport, but it was this arrested thing that really stuck out to me. 17% were arrested. And so when we did the focus groups with officers around this time, there was two things that popped up that I want to tell you about. One was the arrest. When we would ask why, what was that happening at the scene that resulted in an arrest? The major thing we heard was that it was because people had warrants out. So the court was looking for them. They were currently in the system. They had a warrant out, and the officers were like, we can't leave somebody at the scene after they have a warrant. So I thought that was interesting, wanted to explore that more. And then the other thing that they said was, we're sick of giving it to the same people over and over again. And when I could look at the data, I could see they weren't actually giving it to the same people over and over again. Out of about 120 people, I think there were 6 repeats in there. So I was a little bit surprised that that attitude was there. But what we did after that to really dig into it is we did a totally separate study that I want to just briefly tell you all about. So the vast majority of naloxone is provided by EMS. So I wanted to know, like, well, how frequently is it that people are even repeats? When EMS comes and they get naloxone and they're resuscitated, how frequently are they resuscitated again? So we did this study. We looked at every single naloxone administration from 2011 through 2016. What we found was that only 13, I say only 13, but 13% of people were repeat naloxone administrations. 10% of people who received naloxone via EMS died at follow-up. I should tell you that I have replicated this study and not published it, but that repeat rate has increased. It's about 24% now of individuals that receive naloxone have a repeat event. But when we looked at those deaths at follow-up, so who was dying after they received naloxone, what we found is that 65% of those that died were older adults. They had an average age of 63 years old, and they were dying from things like pulmonary disease, heart disease, dementia. They were not dying of drug-related deaths. The younger population that died did. Those that did die of a drug-related death tended to be among the younger population and much more likely to have had a repeat. But I think another important caveat here, a lot of people that when we get cited from this or when we talk about it, this bottom finding is the big one that people talk about, which is 80% almost of naloxone patients, so 80% of those revived by naloxone didn't have any additional administrations in the study period, so it didn't happen again, and they didn't die. So they didn't have any, mortality. So many people, and I guess this is very true of my brother, the story I told at the beginning, naloxone was in many ways an intervention onto itself, that just having that experience changed that behavior a little bit. So the next study that we did, going back to that 18-month group, what we decided to do once we had a handle on the EMS data, we had done some research with the EMS data, is we created this quasi-experimental study where we looked at all of that police administration of naloxone, and we found a group of individuals who were of the same age range, the same part of the city, same time period, where they, in similar background events too, we matched on, we did propensity score matching to look at this. And we created a quasi-experimental match group so we could look at what happens if police gave you naloxone versus EMS giving you naloxone. And the outcomes we were looking at there were arrest. And the arrest is both arrest at that scene and follow-up arrest, a repeat non-fatal overdose, so within that 1 or 2 years of follow-up period, and a fatal overdose. What we found, and I mean, again, I put the citations for these papers down there. If anybody's interested in reading them, feel free to send me an email and I'll get it out to you as soon as possible. But the major finding from that, that police events were more likely to result in jail at the initial event only. So at that initial event, if police did respond, you were much more likely to get arrested. What we did also find is it was not for a warrant. It was more often than not for paraphernalia or just simple drug possession. And then in that 2 years following, we found that individuals that police administered naloxone were more likely to have repeat non-fatal overdoses. We did not find any differences in mortality. So when police gave it to you versus EMS. One other thing I should mention, I forgot to mention from that earlier study, was that I think it's 40% or more, between 40 and 50% of the times that police gave naloxone, because we really went through the records, there was only one time that they gave the naloxone incorrectly when EMS wouldn't have given it. But 40% of the time or more when police gave naloxone, EMS didn't even need to give a follow-up dose. They didn't even need to administer at the scene. When they arrived, the person was, up and about. So this is kind of, where my research in this has been. I just want to briefly tell you folks, tell everybody like where it's at now, if you will, like kind of the things that we're looking at now around naloxone. So we do a lot of stuff with like co-response teams, follow-up units, things like that with law enforcement. But really where we're trying to kind of push the envelope, if you will, in the US with research right now is one of them is around law enforcement drug seizures. So there's one study that has shown that where police seize drugs, it actually increases the overdose there. And just briefly, for those of you that aren't really in the know about opioid use disorder, what happens when folks use opioids, they rapidly become dependent on these opioids. When they go through rapid withdrawal from those opioids, they take as much as they were right before that withdrawal period, that they've developed the dependence to, that they've developed a tolerance towards, and they should in fact use much less. And so people use what they were using before, or they use a new supply. And that's essentially what's happening with police seizures. If you have a drug dealer that you've developed some trust with, that the product that drug dealer is giving you, when that individual is no longer there, you are buying from a new dealer where you have no idea what you're purchasing usually. There's no drug testing, sort of robust drug testing in the US, or you're mixing with other substances. So what we've done is we've tried to take that study that was done before that was just at an aggregate level, a statewide level. We tried to look at it very precisely at the community level, looking at where police seize drugs and both the fatal and non-fatal overdoses in the community surrounding that police drug seizure. And what we find is a kind of a ripple effect where there is police seizures of drugs are increasing non-fatal overdoses immediately within about 100 meters within the first 3 days. And then that effect moves out as time goes on. So it's about 100 meters at 21 days, 250 meters at 14 days. But overall, about a 12 to 15% increase as a result of the police seizures in those communities. We did not find that there was a significant effect for fatal overdose events either. The other thing we're doing is I think I have done a lot of naloxone training, and I think naloxone training is especially important for law enforcement to just kind of mostly to detect overdose, like what does overdose look like, sort of education around substance use disorder. But one thing that does concern me in the US especially is overtraining. So that is requiring training for people who have already used naloxone, who know how to use it. And what happens often is I'll just go to training events to just see what they're like, to see how long they are, what's entailed in them. And when I'll go to these events, they're like 30 minutes. I'll have to fill out some information on myself. But if I were to just go to a pharmacy in the US and just buy naloxone, I don't have to get any training at all. So it does kind of irk me sometimes that you can just sort of opt out of training if you have enough money. So I say all this to say, you know, where we're at with it now, what we're trying to do is put in these vending machines. So we're customizing vending machines, and the vending machines will distribute naloxone. And we're trying to put them into county jail facilities right now. We have 3 jail facilities that have said that they would do it. So at exit, people will be able to get free naloxone. But to supplement the training, what we're doing is putting QR codes and business cards in the naloxone kits so that folks can get to this app. The app tells them how to use naloxone if they don't know, where to get more naloxone, and how to get into treatment if they'd like. And so then we've also looked at trying to put a monitor at the top as well to try and train people that way. So I guess kind of in closing remarks here, just my general take, the research I've done on this and still do quite a bit on is, you know, in the US, I think the issue is that of course police should have naloxone. So I say this, if there's any reluctance that comes through that it doesn't seem like I'm saying that, police should have naloxone because police are gonna be around people who overdose and situations where people overdose. But a lot of other people in our society should have naloxone as well. I mean, I have naloxone at my home. I encourage everybody to carry naloxone with them. So again, I really just see law enforcement as the beginning of a larger community distribution efforts where you're trying to get it into those high risk areas where people can use it to respond to an overdose. But I think the big situation for me is how do we in the US, and from what I understand, some places in Europe, this has been figured out. How do we not send police to the scene of a medical emergency? Because when police are there, that's when we see overdose increasing, arrests increasing at the scene, which may be unnecessary at times. So I will stop there and turn it over to Brandon. And yeah.
Hey, thanks everybody. Can you hear me?
I can hear you.
Can you see this slideshow?
Yep, looks good.
Okay, great, thanks. So I'm Brandon Del Pozo. I'm a postdoctoral fellow at Miriam Hospital in Brown. Actually got connected with Dr. Ray and have been doing a lot of interesting work. I think his access to data is makes a lot of researchers jealous, so it's great to be part of that team and see what he's coming up with. I'm going to take a slightly more personal approach to naloxone, just based on my experience as 23 years as a police officer, 19 in the New York City Police Department, and 4 as the chief of police of Burlington, Vermont, which is Vermont's largest city. Still small in many respects, about 50,000 population in a county of about 210,000. So this is a daily news article back from 2016. It's a pretty pro forma article. I know a lot of the folks in that picture. There's Chief De La Torre, Commissioner Susan Herman, and it's NYPD cops honored saving lives with an anti-overdose drug, naloxone, in Staten Island. Staten Island was the genesis of the naloxone program for the New York City Police Department, because as Brad alluded to, our present wave of opioid overdoses in the US started with analgesic pills, Oxy, Vicodin. This took root in New York City in the working class borough of Staten Island, predominantly among young white users. And that caused an alarm that led to the NYPD looking to start carrying naloxone. So this article is from 2016. Things weren't always this simple, and it wasn't always this unambiguous. And looking at the situation in your neck of the woods in Scotland, the UK, etc., it seems as if, honestly, you're about 5 years, 6 years, maybe 7 years behind in the thinking here, which surprises me. I just assume everybody's ahead of the US when it comes to progressive thinking. So the original obstacle was actually not the police, but the Regional Emergency Medical Services Council of New York City. I worked at the time that this was being considered in 2013 in police headquarters. I worked for the 4-star chief of department, the highest ranking police officer in the NYPD. The NYPD has 50,000 employees and 38,000 police officers. And the commanders in Staten Island had come to headquarters and said, as commanders, we want to start piloting a naloxone program. We have a lot of our residents dying of these pills. We need to do something. It's a safe way to reverse overdoses. And the people who fought it were the people who regulate paramedic and emergency medical technician practice, right? They said, this is a medicine that you're administering. We're the people who administer medicines. This is not something that lay people do. This is our expertise. Call us. They said, however, we would support one part of your unit, your police department, if you insist. There is one unit in the NYPD that could administer naloxone based on the New York Regional Medical Services Council standards, and that is the SWAT team. The New York City Police Department's Emergency Service Unit, which is their tactical and rescue unit, are all trained at least as basic emergency medical technicians. Many of them are paramedics. They all have advanced medical training. So they said, if you insist, we'd let the SWAT team carry naloxone because they're on par medically with our emergency medical technicians and paramedics, but a layperson shouldn't be able to do it, and a cop is basically medically a layperson. One of the things that really changed this was and I'll skip ahead because we were using the more difficult to administer ones on the left. We have to add the little nozzle and take it out. But now that it's a nasal spray, like all of those objections, as far as feasibility, ease of use, training, all of it just completely disappear. And then we have the fact that lives were being lost at an astronomical rate. So for a year or two, that was the objection. I remember writing as the person working for the chief, I wrote the letter to the Staten Island commanders on the chief's letterhead. I'm the chief. I've spoken with the people that set the standards. You're not ready to do this. It's too complicated of a medical process. Call the paramedics, but maybe the SWAT team can do it. That's the letter that I wrote that was signed by the chief of department to kibosh this. But we're at a completely different place now. And I think looking back, we should feel embarrassed about our initial approach. So time goes by. Now it's 2014. The overdose epidemic is continuing to rise. The New York State Attorney General found $1.2 million to start a naloxone program in the New York City Police Department. And they were finally able to get it going just based on the need to respond to the sheer magnitude of the overdose crisis. And this is just this is just cut and pasted from I did a Google search of like NYPD, naloxone. These are the images that come up, just cut and paste them in. So this is over the years, right? The NYPD just did a good job of advertising and celebrating the occasion of officers saving lives. You could see that, you know, from different precincts, from the Bronx to Brooklyn to Staten Island, when partners make saves, they hold the box of naloxone. If you Googled this now and did an image search of NYPD naloxone, you'd see dozens of these. It's just become a normal thing that rank and file patrol officers do. It's not paramedics, not EMTs, not the SWAT team. The men and women you see here, I assure you, having worked in that agency for 19 years, these are the everyday men and women responding to overdoses on the street as patrol officers in the NYPD. And I think the agency's done a good job of normalizing that practice. So in 2015, I became the chief of police of Burlington, Vermont. It's a progressive left-leaning city. I say it's where Bernie Sanders lives. And my mission when I got there on day one was to make a dent in the opioid crisis. There was no Department of Health in the city. It's a small city. So the mayor said, listen, you're new, you have energy, you have a lot of experience, design a public health response to the overdose crisis. And we did. We were able to reduce overdoses dramatically for 2 years running before the advent of COVID. But it was based on a public health response. On the upper left there are some of my colleagues. That woman who's gesturing is Jackie Corbally. I hired a clinical social worker with 30 years of addiction experience to vet all of my responses to the opioid crisis for their public health implications. She was very instrumental in that. But one of the things that was a ground ball to do right when the moment I got there was to equip the cops with naloxone. So as an aside, I'm jumping the chronology a little bit, but another thing that I did as the chief of police was team up with Johns Hopkins University and some leading experts in health and addiction and come up with 10 standards of care for policing the opioid crisis. You can Google this, 10 standards of care. It's on my own website. But the point is, you have some folks on the right who are, it's funny, I just said that and my phone thinks Google wants me. My phone is now Googling something. So anyway, the folks on the right, like Brendan Solaner, Anika, Amanda, these are Johns Hopkins public health researchers. And the folks on the left are police officers. But anyway, we had them plus 2 U.S. drug czars, the heads of the Office of National Drug Control Policy, Mike Botticelli and Gil Kerlikowske, come up with 10 standards of care for policing the opioid crisis. Some are about reducing stigma. Some are about giving people in prison and jail access to medication-assisted treatment. Others are about diverting people prior to arrest. But number one was focus on reducing fatal overdoses. That's the first standard of care, is to set that bar. That's the analytical North Star. And number 2 was use naloxone. It's the most important everyday standard of care for police response to the opioid crisis, as things that police can do as first responders. So by January 8th, 2016, we decided that we were going to carry naloxone in Burlington. So I came into Burlington in September of 2015. So it was, 4 months to get the program up and running. It was not incredibly expensive. Also, it's a it's a 150 employee police department, so not very onerous in terms of cost. But anyway, it was quite an easy matter to be able to train the police officers in using the naloxone. And again, this is something that if everybody's already familiar with this, it takes 2 to 5 minutes to take effect. Give it some patience. This is an excerpt from a training slide that we use in many states. Brad has been instrumental to getting this training out in Indiana. We advise officers not to give too much of the naloxone and send people into precipitated withdrawal. Give 1, see if it works, maybe give another. By then, typically paramedics are on the scene and they can start an IV line of naloxone and they can titrate properly. Anyway, within no time, by February 26th, our first reversal occurred. A man was found unresponsive behind the wheel of a car. The officers arrested him when he came to. They said, you were driving intoxicated. That's how you got here. That put you in danger. But they had this police and public health approach where they were able to use the naloxone to save the man's life. The social worker that you saw in that photo was able to get the person an inpatient treatment spot in an addiction recovery facility. And they were charged with driving under the influence of intoxicant. So that was the police side of the response. But what I stress about this, life saved, treatment secured, and it was off to the races. There was a point where the police officers were getting to the scene of an overdose before the paramedics to administer the naloxone, just to have the satisfaction of saying they saved a life. And all it took was this initial reversal where literally, if you've ever seen the movie The Princess Bride, I watched it with my son the other night. I've seen it maybe 50 times. There's a scene where the Dread Pirate Roberts is not fully dead. He is mostly dead. And they give him a magic elixir to bring him back to life from being mostly dead. What my cop said to me is, this is the only time in my career where I could take a mostly dead person, do something simple, and watch them come back to life before my eyes and know I saved a life. So much of policing is ambiguous. This is unambiguous, and the cops really embraced it. There is, however, as Brad alluded to, a trust issue. People are worried about getting arrested when they come to. They're worried about their friends getting arrested. They're worried about getting arrested for drug paraphernalia. So there is this problem of people, even with good Samaritan immunity, hesitating to call 911, thinking that the police will come and arrest them anyway. It's very incumbent on agencies to have the type of policies that encourage calling and look at the minor criminal infractions as something secondary, because the goal here is to save lives. So one of the things we tried, which did not work, was to respond to overdoses in the days after to offer treatment. People were not happy to see the police at their door, even when they were dressed in plain clothes. I will admit that we were glad to save the life at the time of the overdose. The follow-up by knocking and saying, hey, we were there a few days ago, can we give you treatment? Very tepid response. There was a burglary suspect that we were looking for, and when we knocked on the door, unbeknownst to us, we were looking for someone else. He jumped out the back window. So one of the things of this process that we learned was if you want to rouse the burglary suspects and get them to jump out the back window, you can knock on the front door under the guise of offering a treatment spot. Other than that, very unproductive. So we abandoned that process. One of the things that police can consider doing is outsourcing naloxone. It does not require a call to 911 to reverse an overdose. It's remarkably simple to use. It reduces the workload for police when you outsource and leave it at the scene. It reduces the volume of 911 calls. And it's a very safe and effective medication, as we've all stressed. So another program that's going on in some places is police not just using naloxone, but leaving naloxone behind at the scene of certain drug-related incidents or for people who request it. So just a few things. This is not data about naloxone per se, but this is about officers using their discretion to arrest people for minor drug infractions. And I bring it up because I think it's instructive, because it also, I think, tracks with the way to get buy-in with naloxone. The most important person in the officer's ecology for whether they arrest or don't arrest, use their discretion or not, is the immediate supervisor. So I think it's really important in general to note that immediate supervisors have tremendous influence over an officer's attitudes and actions in the field. And if you want buy-in into a naloxone program in the same way you want guidance, whether you want a cop to use their discretion or not, expectation of the supervisor is very important. Attitude of the suspect matters a lot to officers' interactions. The problem is that people who are overdosing on opioids don't have the best attitude, right? So there is this need to train police officers to at least understand you may be saving a life, you may be getting sick of responding to these people, but like when you come out of an overdose in withdrawal to a room full of strangers, among them police officers, like you're not going to have the best attitude. You really have to take the high road that you're doing God's work, not that the person's going to get on bended knee and thank you. This, however, this is some more pertinent data. This is about just under 200 responses from police officers in about 25 jurisdictions in 3 different states. So it's a lot of geographic diversity here. Police do have mixed feelings about whether heroin users will use more opioids or heroin if they have access to naloxone. The slight majority agree. The second is harm reduction services that distribute items such as syringes condone a person's addiction. More disagree than agree, but it's about split. There should be a limit on the number of times that people receive naloxone. Most disagree, right? 68% disagree, but there is this element of agreement about that I think is wrong-headed, but it is. I'm just giving you the attitudes that American police have in this survey. They do, however, overwhelmingly believe that everyone at risk of experience or witnessing an overdose should get a supply of naloxone. 78% believe that categorically. And they also, this is something interesting too, 73% of the officers we survey believe a police officer who completes treatment for addiction could be trusted to return to full duty. That surprised me. Anyway, so you can see there's still attitudinal skepticism. There's still attitudinal differences about whether we're condoning or not. I don't believe any of that. I believe you should save lives. But this is just something to be mindful of in the training to contend with these attitudes and beliefs. And I'll close by saying, because I know we want to have at least a little bit of discussion, that my first exposure to Scotland as an American chief of police was when the Police Executive Research Forum went over there to learn how the Scottish police encounter people with knives and don't kill them. And it really changed my thinking. I think that American police officers could stand to shoot and kill many fewer people armed with knives. When people say why and it's dangerous and you shouldn't do it, I say the men and women in Scotland who are predominantly, overwhelmingly not armed with firearms, respond to all of these edge weapon calls and end up shooting and killing virtually nobody. Sometimes they get injured slightly more often, but they are rarely killed by an armed suspect with a knife. They're doing it because they value human life. And 2 years ago, I wrote an article in the New York Times. So this was on, all things considered, and NPRs like the BBC of the States. It said, Chief Del Pozo published an op-ed in the New York Times 2 years ago calling on American police to take lessons from unarmed colleagues in the UK, namely Scotland, to try to rely less on their guns, even when facing someone with a knife. And what I said is, part of valor is taking risks for the right reasons, and the sanctity of human life is a good reason to take a risk. Now, what I'm asking you to do something is to sanctify human life by taking no risk whatsoever. Like you, in effect, whether you realize it or not, by your innovations and your culture, we're using what you do to ask American police to take more risks to save lives when people are armed with knives. What I'm asking you as an American police officer is to sanctify human life by carrying and using naloxone, which is taking no risks whatsoever. So I think who's coming up on the better end of the sanctifying of life versus risk ratio are the Scottish police. So thank you very much for your time, and I'd love to hear your thoughts.
Thanks so much to both of you. Really great to hear both the first-hand experience that you've had and about some of the academic evidence behind these programs as well. I would love to have a little bit of discussion here with and perhaps bring in Kirsten and Jason Q to hear a little bit about how what you've heard so far sort of resonates with your experience in Scotland and Thames Valley, respectively. Perhaps Kirsten, we could start with you, and do feel free to share your thoughts. But some of the potentially interesting points of comparison that occurred to me were around attitudes of officers, some of the issues with managing arrests and drug seizures, and the different roles of ambulance and police and sort of managing that in practice. But Kirsten, I mean, can we start with you and hear your initial impressions?
Thanks. Yeah, how to sort of summarise all of that. It's really useful information, and thanks very much, everybody. I guess just to sort of aside a couple of things. Scotland's pretty unique in that we've had a national naloxone programme since 2011, supplied over 80,000 naloxone kits, and the involvement of police in the project has always been something that we've been keen to do, and a lot of similarities from what's been already described about the States, and obviously Gary's given a good picture about where we're at with Scottish Police. One of the most difficult things for us has been the absolute controversy that's been created around the project, namely by the Police Federation, and that's been really unfortunate for the police that have attended as participants on the training, because you're starting the training on a backdrop of this controversy and really trying to sell the idea of naloxone rather than just being able to get the facts across. So that's been really difficult, and especially when a lot of the information from the Police Federation has been highly stigmatising and screams, should we really be saving the lives of these people? And I think that's been a really unfortunate element to the Scottish programme. It's really difficult to provide that training when you are used to providing it to providing training to people who really believe in the benefits of it. So it's been quite a different dynamic and change in tact a bit on that with police. I have to say though, the majority of police have been absolutely up for it. There has been a percentage of police where the questions that are asked in training, I could probably write a book about now, and certainly some of the points that have been made have been stigmatising. People asking the question about this being a stick and plaster approach, which really irks, because the reason what that comes from is a lack of understanding about all the other efforts that are in place to try and address drug-related deaths. We have, the highest rates of drug-related deaths across Europe, but actually it's horrific the number of overdoses that are occurring, and we can't get away from that. But we then shouldn't say, well, because the system and drugs policy is failing people, that we'll just not bother doing anything about the situation that's presented in front of us. So I think that's been a challenge. It's been difficult, and we've got a lot of work to do around some of the attitudes around policing and how we deal with people who use drugs. So yeah, I guess those are the main things. Really interesting discussion about the necessity of calling an ambulance. So we still have that as a key part of our training to lay people and to police officers, that this isn't to replace phoning an ambulance, but I absolutely understand that often by the time the ambulance gets there, you're not any longer dealing with a life-threatening emergency. But that it's an interesting discussion to have, and certainly a lot of people who use drugs, who the naloxone programme is primarily aimed at, don't call ambulances for the reasons that you talk about. And certainly we wouldn't want to see a situation where police were always being sent to overdoses, but in the circumstances that we've seen where police have used naloxone so far in Scotland, it's been really refreshing to see that it's been all the opportunistic stuff that we thought it would be, being called to a concern for person, being flagged down in the street, coming across people, that type of activity where police can be equipped with the knowledge, the skills and the tools to be able to deal with something opportunistically rather than being called to the scene, I think's really what we wanted to see from the project. So really fascinating to see how that unfolds. And I'll stop there given the time. Thanks.
Yeah, apologies to those who need to go, but Jason, I'd love to hear from you as well. I understand that your program is also in its relatively early days and it's mostly on a volunteer basis, but it'd be really great to hear of your approach there and what you've sort of reflected on after these presentations.
Thank you. I've got a very short presentation I can share actually, because that will demonstrate the evidence base, and which is quite compelling in itself. So can you just give me a thumbs up if you can see that in front of you? Sorry, I didn't see your thumbs up. What did you say? Yeah, brilliant. Thank you.
Yes,
sorry about that. Right, so really briefly, this will take me a couple of minutes, no more. Policing, working in partnership with health partners, can evidence the locations, if you like, and the hotspots for drug-related deaths. And we've done that across the southeast here. And these are slides that I won't get tired of showing, not ever, because these absolutely demonstrate where the areas of high harm are, and they galvanise the attention of the key stakeholders in that locality. And it's that accountability to reduce harm where we are answerable to the public. So policing, health, and the wider cross-sector experts, if you like, from drug services, homelessness, mental health, and a range of other business sectors come together within communities partnerships to reduce harm. Looking at naloxone distributions, we work with the ambulance service to measure naloxone administrations and their locations supplied by the ambulance service, and you can see here the repetitive hotspots, so Southampton, Portsmouth and Reading being frequently in the top 3. So working with those locations, naloxone starts to frequently become the #1 topic or #1 on the agenda, and that's police within that partnership hosting that data. Here again, hospital administrations, so we have 1,000 naloxone administrations by the ambulance service within the year, just in those locations. Hospital admissions are rapidly increasing, and then we can use our data, if you like, to drill down into where exactly these overdoses are happening upon the streets. So this gains the attention, if you like, of our neighbourhood teams. So our safer streets officers, if you like, are frequently, day to day, out of hours, 24/7 in these locations, and they are ripe for the carriage of naloxone, and also working through their partnerships to reduce harm wherever they can. So police officers are actually approaching drug services on a voluntary basis to be trained and also to destigmatise the carriage of naloxone, because as Kirsten just mentioned a minute ago, more often than not, if two people use together and one overdoses, the other person might not hang around because of the fear of prosecution. What we want that person to do is to safely, in the knowledge, either have naloxone and administer it in a peer-to-peer program, but at least ring the ambulance. We need that ambulance to come at all costs. And I think, this is from brutal experience. People will run off from an overdose, sadly, and it's that fear of prosecution, fear of the punitive response from policing. Now, police officers carrying naloxone can dissolve that stigma, dissolve that fear instantly in these areas of highest harm. And obviously, we've worked with Release Drugs here about the take-home naloxone programs too. So this is quite encouraging about where naloxone is available within the communities, but police have a significant role here too, and it's leadership such as ACC Ritchie. It's that leadership that can legitimise for other policing areas the carriage of naloxone, and I absolutely commend what Durham are doing. I absolutely commend what Police Scotland are doing, because they're leading the way, and it's in that relationship of a brittle relationship with the Police Federation of England and Wales. So I've been working with the Police Fed. So in my force, we have naloxone in police custody. We've had that for a number of years actually, and we have take-home naloxone to those detainees at highest risk of harm. That's been in operation for a number of years, and we're just starting a needle exchange programme as well within the custody setting. Now that's progress, but we still haven't got cops on the street routinely carrying naloxone. So it's you know, you're compromising that ethos that we're trying to show. So where we are now, the Police Federation and the NPCC are discussing a joint position. The Police Federation, I feel, will not condone the ethos of every police officer carrying naloxone, but they will in the areas of high harm. And I think it's those officers on neighbourhood teams that will be carrying naloxone, seeking it voluntarily at their drug services. And I think that's a good compromise to start with. But Brenda mentioned a little while ago, we are behind. You know, we need to really step forward, and it's testament to the leadership of Mr. Ritchie and Jason Meacham that we're here. So yeah, my respect. But they're my views.
That's great. Thanks so much, Jason. And we actually do have a couple of questions on those issues that you raised around, you know, federation concerns and oppositions. And again, apologies to those who need to go. And perhaps if I could ask for the presenters time, just another 5 minutes, perhaps. I have a question for Brandon. Can Brandon comment on whether he encountered similar issues with the equivalent of the Police Federation in New York and Vermont? And if he was able to win them over, and how?
Yeah, just checking that you can hear me. So it wasn't, I remember I was parked in my police car in my driveway talking to the head of the union, and there was not a big groundswell of opposition in the Vermont Burlington Police Officers Association, also not in the NYPD. It was done pretty much by fiat in both cases. But I do think that when the jury was out, so to speak, until the first life was saved, and the two cops that administered naloxone, officers Darren Kennedy and Oren Byrne, they're in fact, Oren Byrne, I think, is actually, okay, he's Irish. But the point is, like, just by way of like, born there, by way of trivia, these were regular patrol cops. They weren't social worker cops. They weren't especially progressive cops. But when they saw the person come back to life and they saw the public's approval, it really transformed them. So to be honest, no, we didn't have the pushback. And I was surprised to see the pushback so strong in Scotland. And just watching a person come back to life kind of like swung the union's decision in favor of naloxone.
Great. Gary, could I ask you a question? Of the 10 users in the test of change pilot so far, did officers attend those as police response or as a medical emergency, or did they just happen across those individuals while they're carrying out their normal duties?
Yeah, I think Kirsten mentioned this. It was as they anticipated in the course of their duty. So these are not, our control rooms don't know what police officers carry naloxone and what and who doesn't. We don't denote that on our systems. So these are calls that police officers would have gone to in any case, whether or not they were carrying naloxone. So they're concerned for person calls. They are, as Kirsten mentioned, calls for somebody's flagged somebody down in the street, calls for people who have maybe not seen someone before. One of the uses was actually a police officer. This was other work that we've been doing with our partnership in Glasgow. A police officer was taking a person who was living with addiction his methadone, because there's been times through the pandemic where people had struggled to actually get their methadone, using a methadone treatment program. And the officer was helping out the pharmacy and delivering methadone to this individual, and never got a response at the door, and forced entry and found him in an overdose. And again, like Brandon says, and thank you very much for your kind words, Brandon, by the way. I'm going to email you after this if you don't mind.
Sure.
You know, a miraculous return to life. So it's very much in the situations where police officers are going to find themselves anyway.
I just wanted to say really quickly that I do get a lot of pushback from my union about anything having to do with Scotland's approach to knives. So it is ironic the way the culture is different, but if I say, I bought them all the shields that you guys have, I gave them all the training, they said, anything that you want us to do that Scotland does with knives is just going to get our cops killed. I don't know what they're doing over there, but it's dangerous and we completely reject it. We need to use our guns. Yet, when it comes to naloxone, they very quietly embraced it, waited till it worked, and then openly embraced it. And it's just so ironic that there's this juxtaposition between the two labor unions about these things that just seem so counterintuitive. So I just had to remark on that. Thank you.
Thank you very much. And again, just in a final note, just on the staff association and the questions I saw in the sidebar about how we get the federation on side. I say let the federation catch up themselves, and really, again, to be frank, don't waste time in trying. They are not a constructive partner yet. Their heads are not in the right place, and their position is not right nor conducive with a modern progressive police force's values. So they need to catch up. They need to catch up quickly. And as I say, my advice to anyone out there who's considering this, I'm delighted to hear about the NPCC and the Federation perhaps coming of England and Wales, who are more constructive than the Scottish Police Federation to begin with. I'm delighted to hear about them coming up to it with a joint position. That's one step. That's one positive step. But they've got to catch up. And they shouldn't get in the way of police services making the decision to actually supply their officers routinely with naloxone.
Thanks, Gary. I have another question, and Kirsten, perhaps I can put it to you. What can we do together to raise more public awareness of naloxone and drive demand for it?
Well, this is a perfect question for me because I forgot to mention a couple of things I was going to say. Firstly, about the police inside and how that has actually itself raised awareness. So, as Gary mentioned in his presentation, it's quite public. The actual physical kits are quite a statement in themselves, being on police officers' belts. But because there's been a lot of media attention around this, there have been radio interviews and other things that have generated more interest around the public. I think the public are generally interested in what the police are up to. And from the news articles, we've had cases of members of the public calling into drug services to say that they'd heard about naloxone because the police are carrying it. How can they get their own kits? We've had staff in shopping centres asking the police around what these naloxone kits are and that they should probably get themselves some. So I think it's actually having a really positive effect on community awareness in itself because it's probably reaching a wider group or a different group of people than we've been able to before with awareness raising campaigns. So as part of the naloxone programme, I mean, we've had ours in Scotland since 2011, and it still amazes me the number of people who don't know about it, and we have done mass advertising around it. There's currently a poster campaign in Scotland and in parts of England as well just now. We've, tried to do as much community work as we can around it, but I think this project in particular is raising awareness among a different group that's shown to be extremely useful, even in the few weeks that it's been operating so far.
That's great, thanks, Kirsten. And I'm really aware of time and how much we've overrun, but Jason Meacham, I wonder if I could sort of turn to you for some final sort of concluding thoughts on this workshop series and sort of where to next for these programs, both at Durham and more broadly across the UK.
Yeah, thank you, Lucy. Thank you, Brad, Brandon, Gary, Jason, and Kirsten for popping on today, and all the presenters who have been on the last couple of weeks worth of lectures. I think what's clear today is that there's a mass drive to get naloxone into the hands of people that need it, and how we go about that and do it quickly, I think, is the important thing. I think people like Jason, who are very, very active on Twitter and Facebook, etc., take part in that quite vociferously. And I think Jason's recollection that the Fed and the NPCC are coming up with a joint approach is a really, really positive step. I think if you were listening into the other week's discussion with PHE, Public Health England, on, there's a consultation coming up about naloxone and the use of it. I think it's important for us as an organisation, as police forces and public health teams, to have a joint approach on that and to actively get involved to see how we want to drive the use of naloxone and the spread and the availability of it in the future. And we've got a real opportunity here to demonstrate the proactive use and to make the legislation fit on around us we want it to do. So thank you everybody who's participated so far, and I'd like to say if anybody wants to be in touch with me about any particular details of how we've run this in Durham, feel free to email me.
Great, thanks Jason. I echo all your thanks to the presenters and to all our attendees. Just a reminder that we have recorded the session, so we'll make that recording available to you in due course, and also we will produce a workshop report as well, which hopefully will be a resource moving forward. But thanks again to all the presenters and attendees, and we'll be in touch again soon.